Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 28, 2025. This video is on a Lancet article titled Blood Pressure Lowering Efficacy of Antihypertensive Drugs and Their Combinations, a systematic review and meta-analysis of randomized double-blind placebo-controlled trials. There's an accompanying commentary titled Better Blood Pressure Control with Predictable Drug Dosing. Hypertension remains the top modifiable risk factor for premature cardiovascular death. Each millimeter mercury reduction in systolic blood pressure reduces major cardiovascular events risk by 2%. Current guidelines lack drug-specific efficacy data, unlike LDL cholesterol targets in lipidology. This meta-analysis assessed blood pressure-lowering effects of monotherapies and combinations from 5 major classes: ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics. This was a systematic review of 484 randomized controlled trials. The cohort comprised of 104,176 individuals, mean age 54 years, 55% by male. The trial spanned from 1990 to 2025 with follow-up of 4 to 26 weeks. Mean 8.6 weeks follow-up. Statistical models adjusted blood pressure response by baseline values and dosage. Fixed effects meta-analysis standardized to baseline systolic blood pressure of 154 millimeters of mercury. Developed efficacy calculator validated on dual and triple drug trials. What did they find? Monotherapy at 1 standard dose reduced systolic blood pressure by 8.7 millimeters of mercury. Doubling the dose added only 1.5 millimeters of mercury. Calcium channel blockers and thiazides had steeper dose response curves versus beta blockers. Dual combinations reduced systolic blood pressure by 14.9 millimeters of mercury. Each dose doubling added 2.5 millimeter decrease. Triple therapy exceeded 20 millimeter reduction. This is high intensity antihypertensive therapy. 79% of monotherapies were low intensity, less than 10 millimeter decrease. 58% of the dual combos were moderate intensity, that is 10 to 19 millimeter reduction, and 11% were high intensity, greater than 20 millimeters of mercury. Limitations: trial level, not patient level data. Ethnicity, BMI effects not fully modeled. Estimates reflect short-term effects with high adherence. Key takeaways: drug class and the number of classes were major efficacy drivers. Use predicted mean reductions, not blood pressure variability, to guide treatment choices. The accompanying commentary said, why does this matter? Blood pressure variability and clinical inertia limit effective hypertension control despite decades of progress. The findings of this study, that is monotherapy reducing systolic blood pressure by 8.7 millimeters of mercury and dual therapy by 14.9 millimeters of mercury and triple greater than 20 millimeters of mercury. The commentary had caveats: clinical heterogeneity, short trial duration, high adherence, limited generalizability to older patients with isolated systolic hypertension. The key takeaway was predictable, evidence-based dosing offers an LDL-like paradigm for blood pressure control, potentially reducing overtreatment, visits, and workload. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.